Hello and welcome back. In this video, we're going to be discussing Chapter 7 and Chapter 9. In Chapter 7, we were discussing motivational interviewing. In Chapter 9, we're discussing treating comorbid disorders. So let's talk about most motivational interviewing first. So motivational interviewing is a approach that stems from the person-centered philosophy of being client-centered, but is more directive than what we say person-centered Rogerian therapy would be. It was developed by William R. Miller and Stephen Roenick. It helps clients explore and resolve ambivalence. Through a motivational interviewing, clients are not looked at as they have diseases. They looked at they have ambivalence. They're resistant to change, right? But the goal for motivational interviewing is to enhance and develop intrinsic motivation. Remember, external motivators don't last, where internal motivators are always there for us. So we want all change to be internal or driven from within. So the core principles of motivational interviewing, you want to be able to express empathy. You want to do this through reflective listening, really listening to our clients, letting our clients know that they're feeling heard, not judging our clients, letting our clients actually understand that we understand their feelings that they're having. You want to develop discrepancy between current behavior and personal values and goals. But again, you want to actually play ignorant to this. You want to make that sure that the client is developing discrepancy between their current behavior and personal values and goals, right? You want to be able to roll with resistance. Avoid direct confrontation. Because again, some of our clients are resistant. When you talk about dealing with clients dealing with substance abuse, some of our clients are mandated from the courts and don't have a lot of motivation to participate in treatment. So you want to be able to roll with that level of resistance. Then you want to support self-efficacy. Encourage belief in the ability to change. Remember, self-efficacy is the belief a person has in themselves about a specific task, right? Self-efficacy, it goes across a whole bunch of different spectrums with human beings because we have a bunch of different tasks that we do, and how efficacious you feel at that task will determine your level of motivation of engagement into that task. So the spirit of motivational interviewing. We talk about collaboration, evocation, and autonomy. Well, so we want to collaborate rather than confront, because again, we want the client to become aware of things. The client needs to develop their own level of what we call change talk, right? We don't want to point things out. We want the client to point things out because they have to evoke that change talk. So we want to collaborate with them and not confront them on their behaviors, as we want them to become aware. Education over education. Again, we want to make sure the clients becoming aware of things and they're teaching themselves or whatnot, rather than us educating them on what they need to do or whatnot. We want them to be motivated to actually pull out the information. And autonomy is very, very important. We're talking about those principles of Kitchener's principles of moral principles or whatnot that we use for our ethics or whatnot. It's same thing plays here, right? We don't want to be the authoritarian. We want the client to be the expert in the room. We want to give them the autonomy to make changes and grow and be independent. So the key techniques for motivational interviewing, we call them ORs. We want to use open-ended questions. Remember, those are the questions that open up conversation, let the client disclose or discuss things more. We want to use affirmations. We want the client to we want to affirm the client's thoughts or whatnot and positive steps. Reflective listening. We want to be there and listen to the client and be able to reflect on what they're saying so they can understand that they're feeling heard. And we want to summarize. We want to continue to summarize throughout that session. When the client says something, we want to summarize what they said so they can provide clarity of what they said, and for them to become more aware of some of the things they're saying about their behavior and about their current situations. So let's talk about the trans theoretical model. Those stages of change that we utilize in substance abuse to help us see where clients are. We have that pre-contemplation stage, the stage where the client feels that there's nothing wrong with, they don't have an issue, right? We have that contemplation stage where they may realize that they have an issue, but they're not doing anything about it, or they're not making any change. We have that preparation stage where they're preparing to act, right? They're preparing to act, preparing to make steps or whatnot. So again, those first three steps, stages or whatnot, is where we want to use motivational interviewing, as we want them to become motivated to make and evoke their own change talk and evoke their own change, right? Then we have the action stage. That's when they're actually acting towards making changes in their lives and putting steps towards those things. And then we have the maintenance stage where they're trying to maintain their recovery. So applications of motivational interviewing. We want to utilize substance abuse and addiction. Um, We want to help behavior change, diet, exercise. We want to make sure that they're taking steps to become mindful of where they are and whatnot, and increase their healthy habits. Mental health and therapy adherence. We want to make sure that they're adhering to their mental health treatment and their therapy adherence, because we're going to talk about comorbid disorders here in a minute. And with criminal justice and education settings, we want to make sure that, again, a lot of times with substance abuse, there's a lot of emphasis on their legal issues, their involvement in the criminal justice system or whatnot. And we want to make sure that again, sometimes substance abuse can impact their ability to finish their academics, to it can stop their education. We want to make sure that we enhance their ability to be successful in academia and with their educational motivations. So the strengths and limitations of motivational interviewing. We want to be non-confrontational. It's evidence-based. Enhance the client's autonomy, right? And let's talk about some of the limitations of it, right? Because being non-confrontational and being evidence-based and enhancing their autonomy are positives, right? But the limitations of it requires training and skills, and maybe less effective with highly resistant clients. So those are some of the limitations. So just to summarize what we just discussed, motivational interview is a respectful and powerful approach to facilitate change. But you want to be more person-centered oriented, and you're really trying to drive the client's motivation to change. And remember, we see them as being ambivalent to change and not having a direct issue that is resistant to change. So we want them to evoke their own change talk, and we want to be there using those micro counseling skills and that person-centered or client-centered directives or whatnot to help pull out the client's awareness of who they are and what's motivating them. We want to emphasize empathy, autonomy, and collaboration, and this is valuable across various settings and populations. All right, let's move on to chapter 9, where we're talking about treating comorbid disorders. So, a comorbid disorder is the presence of both substance abuse and a mental health disorder. It's often referred to as dual diagnosis or co-occurring disorders. Some common combinations with substance abuse is substance abuse and depression, substance abuse and anxiety, substance abuse and PTSD, and substance abuse and bipolar disorder. So there's high rates of comorbidity in treatment populations. Samsha in 2022 had a research study where they looked at 9.2 million adults in the U.S. that have co-occurring disorders or comorbid disorders. It leads to poor treatment outcomes, higher relapse rates, and increased risk of hospitalizations. And the reason that it can increase higher relapse rates because if we just focus on the substance abuse treatment and don't focus on the mental health, which can be the major influence of their substance abuse, the relapse rate is there because we haven't provided treatment for the etiology of that issue, and that issue can resurface itself. So theoretical perspectives. We're talking about the biopsychosocial model, integrated treatment model, self-medication hypothesis, and developmental and environmental factors like trauma, ACEs, environment, negative environment, attachment. A whole bunch of different developmental and environmental factors can play a role in comorbid disorders. Assessment consideration. So you want to utilize standard screening tools for both disorders. Which disorder appeared first is really important, especially like with PTSD. Did the trauma and the traumatic event happen before substance abuse began? That means if it did, the substance abuse is probably going to be a symptom of the trauma, right? Whether symptoms are substance induced, level of functional impairment, are they impaired in just academic, occupational, or social areas of their life? We want to use collaborative, culturally sensitive assessments. Again, being culturally sensitive means we're going to look at that client as an individual, a unique individual, look at their culture and see how that plays a role in their substance abuse or whatnot. And we want to make sure that we are have knowledge and skills about that client and their culture. So treatment approaches. We want to use integrated approaches when we talk about comorbid disorders, right? Both disorders are addressed simultaneously by one team is really effective. Sequential treatment is less ideal where we actually just focus on one area because again they're impacting each other. One disorder treatment for the other. Parallel treatment is treated at the same time but in separate systems. which is a really, really good approach. Again, with the sequential treatment, when you're talking about one treatment disorder or the other, that can be difficult because, again, they play a role off each other. We want to make sure that we are looking at the whole client and providing holistic care. So you have integrated treatment, sequential treatment, and parallel treatment. So evidence-based interventions that's utilized for comorbid disorders is motivational interviewing, which we just discussed, cognitive behavioral therapy, which you saw in the theories video, medication-assisted treatment, contingency management, and trauma-informed care. So some of the key counselor competencies that treating comorbid disorders need or need to be in place are cultural humility and sensitivity, which we just discussed, interdisciplinary collaboration. Again, you have to have a multidisciplinary team that's going to meet with each other and discuss the client and looking at the client as a holistic individual. An ethical decision making model with current needs in mind, making sure you're making a correct ethical decision for the client in terms of their care. So barriers to effective treatment. Fragmented care systems. Again, you have care systems that have fragments of care, not looking at the whole person. Stigma, both internal and external. Again, mental health and substance abuse have a stigma, both from the client within the client itself and in the society itself. Lack of integrated services. Again, we want to integrate our services together and be a whole treatment or multidisciplinary team, and utilize those services together as a best practice. And adequate training of professionals. Individuals treating comorbid disorders that don't have the proper training or not adequately trained in specific areas that are needed for treating of comorbid disorders. Summary and best practices in terms of comorbid disorders. Again, we want to treat both disorders together using an integrative model, which is the best approach. We want to emphasize collaboration, evidence-based approaches, and client-centered care. We want to build a strong therapeutic alliance to address complex needs. And we want to address relapse prevention and long-term recovery. And that's really important. Relapse prevention is really important because, again, if you're not treating both and using that integrated approach or whatnot, the other can influence the other and it can resurface, right? And we want to also talk about long-term recovery. Long-term recovery, substance abuse has been proven to be an addiction, right? So, again, they're going to always have to be in some type of maintenance or recovery planning or whatnot because we don't want them to resurface, right? So, we want to make sure we're practicing and addressing that relapse prevention and long-term recovery because, again, we're talking about a long-term disease. So we're talking about maintenance services and clients continue to provide, going to meetings, going to CR recovery meetings, going to AA meetings, staying active in things that can support their recovery.